Anatomically programmed technique and technique charts. And this is part 2 from chapter 13 in the Faber-Johnston book, Essentials of Radiographic Physics and Imaging. Anatomically programmed techniques, or anatomic programming. It is a radiographic system, and it allows the radiographer to select a button or a particular button on the control panel, and that button will represent an anatomic area for which a pre-programmed set of exposure factors are displayed and can be selected. So everything is calibrated into the control panel already. So whatever button you push, it already has the KVP, the MA, the seconds. It has everything calibrated in it. And a lot of the times also the SID. They are controlled by an integrated circuit or a computer chip that has been programmed with exposure factors for different projections, different positions of different anatomic parts being examined. Now, once you push a button for a particular exam, you can go ahead and adjust the exposure techniques as well. So even though it's already calibrated in there for you, doesn't mean you can't tweak them. So you can go up or down in kV, mass. You can tweak about anything that's already preset in there. Anatomically programmed techniques and AEC are completely different. The anatomically programmed techniques are programs that are put into the control panel. For each different exam, they select the KV, the MA, and the seconds that we will be using for each programmed examination. AEC is going to select the detectors that we use for each examination. But when anatomically programmed techniques are used in conjunction with the AEC, the system not only selects and displays the manual exposure factors, the KV, the MA, and the seconds, but also displays the AEC detectors to be used for each examination. For example, if we press lungs PA or chest PA, it's always going to be different on each equipment that you use. But let's say we put lungs PA. We hit that button and it's going to select 120 kVp for us. It will select the upright Bucky because it's programmed in there that we do chest x-rays standing. And then it's also going to select the 2 outside AEC detectors for the right lung, or for the right and left lungs. So now we have everything set. You can go up and down in your KV, your mass, but everything is pretty much set. The only thing you need to do really is you need to still have your judgment on the body habitus. So if a patient is larger, you're gonna select large patient. And if it's a pediatric, you'll select either small, medium, or large child. So there are things that you can still tweak and maneuver, but everything is pretty much already set for you. Anytime you're using any kind of machines, we have to make sure that we have quality control and we're, providing proper maintenance for them. So just like every morning you come in and you do a tube warm up, to make sure that the heat units are at a certain percentage, make sure the tube is warm. That will protect the tube from cracking, right? So same thing with the AEC, we have to have quality control with that too. So it is very important that systematic equipment testing be performed to ensure that proper system performance, calibration, and quality control testing are essential procedures to maintain the proper functioning of the AEC system. So we have to make sure and do quality control checks on pretty much every part of the x-ray machine to make sure it's working, and proper maintenance as well. For an AEC device to function properly, the radiographic unit, including the IR, and the AEC device must be calibrated to meet departmental standards. And this will be different everywhere you go and every x-ray room you work in. When a radiographic unit with an AEC is first installed, the AEC device is calibrated. And then it is recalibrated at intervals after that. The purpose of calibration is to ensure that consistent and appropriate exposures to the image receptor are produced. Failure to maintain the regular calibration of the unit can result in 4 different things. Number 1, a lack of consistent and reproducible exposures to the detector. 2, an overexposure of the patient. 3, poor efficiency of the imaging department. And 4, possibility of improper radiographic image interpretation. The AEC device should provide consistent exposures to the IR for variations in technical factors, patient thicknesses, and detector selection. Several aspects of the AEC performance can be monitored by imaging a homogeneous patient equivalent phantom plus additional thickness plates that you can add to the phantom. The consistency of exposures with varying MA, KVP, part thickness, and detector selection can each be evaluated individually and in combination by imaging a patient equivalent phantom and measuring the results in milliroentgen for the exposure and pixel brightness levels. Reproducibility of the exposures for a given set of exposure factors that you have selected, and then also the selected detector, should result in MR readings within 5%, and pixel brightness levels for areas within the displayed image should be within 30%. The RT must use AEC accurately, regardless of the type of IR used, and failure to do so can result in overexposure of the patient to ionizing radiation or a production of an image that is of poor quality. The response of the AEC device when changing the exposure variables and their effect on exposure time and brightness in the area of interest are shown in table 13.1 of your book. So make sure and look at that chart there. When using digital IRs, we have to be very careful about preventing excessive radiation exposure to the patient. And it is our job as the RT or the radiographer to select the exposure factors that are going to produce a quality radiographic image, but using a LARA, giving the patient the minimal amount of radiation. Technique charts are very useful tools that help us select a manual exposure technique, or when we're using the AEC, and it doesn't matter what type of IR we're using. So technique charts are pre-established guidelines used by radiographers to select the standardized manual or AEC exposure factors for each type of radiographic exam. The technique charts are going to standardize the selection of exposure factors for the average patient. And the reason is because they want to keep the quality of radiographic images consistent. So it is our job to take these exposure factors from the technique chart, and of course they're for an average patient, so we want to adjust them for a smaller patient or for a larger patient. For each procedure, you'll want to consult the technique chart and look on there for the recommended exposure variables. You want to look on there for the KVP, the mass, even the detectors can be listed, the type of IR, the type of grid used, and sometimes you'll even see the SID on the technique chart. So based on the thickness of the anatomic part that you're radiographing, you're going to select the exposure factors in the technique chart. And the technique charts will have like the centimeters. So if you use calipers to measure the part being examined, you can see how many centimeters it is. And then on the technique chart, it will show you, depending on how many centimeters the part is, what type of technique to use. So if you're using a manual technique, you will need to measure your patient to be able to figure out what exposure factors to use. So for example, if you have a patient that came in for an abdominal examination, so a KUB, we'll position the patient and put the CR on the iliac crest. So CR goes on the crest. And then we are going to measure the abdomen with the calipers through the central ray. So you'll measure the patient, and then you can use a manual technique. And using the technique chart, you can set that manual technique. But most of the time, places that you go are going to have an anatomically programmed technique. So everything will be programmed in the control console, and you really don't have to worry about setting your exposure factors. But this is good if you're using a portable machine, or if you have a patient that's extremely large or extremely small and you need to adjust it, then you need to know around about what the exposure factors are for each exam. Technique charts help ensure that consistent image quality is achieved throughout the entire radiology department. They also decrease the number of repeat radiographic studies needed, and therefore this will decrease the patient's exposure to radiation. But you need to remember that technique charts do not replace the critical thinking skills required by us as the radiographer. So we must continue to use individual judgment and discretion in properly selecting the exposure factors for each patient and each type of examination. Our primary task is to produce the diagnostic quality images while delivering the least amount of radiation to our patient. When technique charts are developed or designed, they are usually designed for the average or typical patient, and they don't account for the unusual circumstances. So patients, in terms of their body habitus, their physical condition, the presence of a pathological condition, this will require us to alter the exposure factors. So these atypical conditions will require accurate patient assessment and then appropriate adjustment of the exposure techniques by the radiographer. A technique chart should be established for each X-ray tube, even if a single generator is used for more than one tube. For example, if a radiographic room has 2 X-ray tubes, one for the radiographic table and one for the upright Bucky, which is very, very rare, each tube should have its own technique chart because of possible inherent differences in the exposure output produced by each individual tube. But like I said, that's very rare. I doubt you will ever see a room that has 2 tubes in it. For technique charts to be effective, the radiographic system must operate properly. A good quality control program for all the radiographic equipment ensures monitoring of any variability in the equipment's performance. We need to make sure that we've got some QA going on there for all of the different equipment. So these are the calipers that I was talking about before. We use these to measure the part thickness. So an accurate measurement of part thickness is a critical condition for the effective use of technique charts. The measured part thickness determines the selected KVP and mass when we're using manual exposure techniques for the exam. If the part is measured inaccurately, then there could be incorrect exposure factors that are selected. So measurement of the part thickness must be standardized throughout the radiology department, and we must always measure correctly, and you're going to measure through the central ray. So wherever the central ray is located on the body, that's where you're going to put the calipers and measure through that area. Because the range of exposures needed to produce a quality digital image is wider, which means it has a wide exposure latitude, the precise measurement of the anatomic part is not critical. So although the technique charts discussed in the chapter use patient measurement to determine the exposure factors to be selected, categorizing the typical patient according to small, medium, and large should be sufficient enough when using the digital IRs. And this is a picture of the caliper used to measure, and it can measure in centimeters or inches. Technique charts can vary widely in terms of their design, but they share some common characteristics. The primary exposure factors of KVP and mass and common accessory devices used, such as the IR and grid ratio, are included regardless of the type of technique chart used. Two primary types of exposure technique charts exist. There's the variable KVP fixed mass and fixed KVP variable mass. Each type of chart has different characteristics, and both have advantages and disadvantages. The variable KVP fixed mass technique chart is based on the concept that KVP can be increased as the anatomic part size increases. Specifically, the baseline KVP is increased by 2 for every 1 centimeter increase in part thickness, whereas the mass is maintained. It's not increased or decreased. The baseline KVP is the original KVP predetermined for the anatomic area to be radiographed. The baseline KVP is then adjusted for changes in part thickness. We must take an accurate measurement of the part thickness. This is very critical to the effective use of this type of technique chart. Part thickness must be measured accurately to ensure that the 2 KVP adjustment is applied appropriately. The radiographer consults the technique chart and prepares the exposure factors specified for the type of exam that we're doing. We pick the mass, the SID, the grid use, and the type of IR, and then the anatomic part is measured accurately, and then the KVP is adjusted appropriately dependent on the size of the anatomic part. So for example, a standard exposure technique for a patient's knee measuring 10 centimeters or 4 inches is 63 KVP at 8 mass using a DR IR, and we'll use a 12:1 table Bucky grid. And then a patient with a knee measuring 15 centimeters, which is 6 inches, is going to require a change only in the KVP from 63 to 73. And that's going to be 2 KVP change for every 1 centimeter change in part thickness. And we went up, in part thickness, we went up 5 from 10 centimeters to 15 centimeters. So that's 5 times 2, and that's 10. So we'll have to go from 63 to 73 KVP. The variable KVP fixed mass technique chart adjusts the KVP for changes in part thickness while maintaining a fixed mass. We don't know the baseline KVP, but ideally the goal is to determine a KVP that adequately penetrates the anatomic part being examined when using a 2 KVP adjustment for every 1 centimeter change in tissue thickness. The baselines can be determined by doing experiments with phantoms. And the phantoms are equivalent to a patient composition of tissues and muscles and bones. So that can give us our baseline. Developing a variable KVP technique chart that can be used effectively throughout the KVP range has proved problematic. Changing the KVP for variations in part thickness may be ineffective throughout the range of the radiographic exams. And because KVP is a variable, radiographic contrast may vary as well, and these types of charts tend to be less accurate for part size extremes. So again, for the average patient, these technique charts seem to work. But if you have a patient that is any larger than average, then it becomes problematic. And the exposure techniques are not what we need them to be to make the diagnostic image. This type of technique chart is better for pediatrics, patients with small extremities, such as hands, toes, feet, things like that are being imaged. So any kind of small parts or small patients, this is a good technique chart for. And this type of chart does have an advantage of being easy to formulate, because making KVP changes to compensate for different part sizes is pretty simple. So this is a fixed KVP variable mass technique chart. And this technique chart identifies optimal KVP values and alters the mass for variations in part thickness. So it's the opposite of what we just talked about, which was the variable KVP fixed mass chart. So now we have the fixed KVP, so we don't touch the KVP, and the mass is going to change. Optimal KVP is the KVP that is high enough to ensure penetration of the part, but not too high to diminish the subject contrast. We still want to have that radiographic contrast. So for this type of chart, the optimal KVP for each part is indicated in the technique chart, and then the mass is varied as a function of the part thickness. So we're measuring to figure out what type of mass to use. So again, we're using the calipers and measuring for mass. Patients can be grouped by size, such as small, medium, large, and extra large, or sometimes on control panels, they'll have actual weight ranges in pounds, such as 100 to 130, and so on. Measuring the thickness would not be required with this type of a control panel. Using consistently higher optimal KVP with digital imaging systems can reduce the variability among exposure techniques for the same or similar anatomic region. So this fixed KVP variable mass technique chart has that advantage of easier use, more consistency in the production of quality radiographic images, greater assurance of adequate penetration of all anatomic parts, uniform subject contrast, and increased accuracy with extreme variation in size of the patient and the anatomic part. The steps involved in technique chart development are similar regardless of the design of the technique chart. So it doesn't matter if it's the fixed KVP variable mass or the variable KVP fixed mass. Designing it is the same. You're going to use the same steps. So the steps involved in technique chart development are similar. The primary tools needed are the radiographic phantoms, calipers for the accurate measurement, and a calculator. And we're using the radiographic phantoms to find the optimal KVP. Once we take diagnostic images using the phantom, the exposure techniques can be taken from that with it, a mathematically estimated and used for the imaging of other similar anatomic areas. A critical component in technique chart development is to determine the minimum KVP that adequately penetrates the anatomic part to be radiographed. One method available is to use the concept of comparative anatomy. And comparative anatomy can assist the radiographer in determining the minimum KVP. This is a concept that states that different parts of the same size can be radiographed by use of the same exposure factors. So we need to know the minimum KVP needed to penetrate the part, and then we can figure out the KVP to use on each part of the entire body. For example, a radiographer knows what exposure factors to use with a particular radiographic unit for a knee that measures 10 centimeters. And we're doing this knee in an AP. So we'll do an AP knee on a 10 centimeter knee. But now we have to radiograph a shoulder. So the radiographer is going to measure the shoulder in the AP and determine that it also measures 10 centimeters. So now the radiographer does not have a technique chart for a shoulder. So the concept of comparative anatomy states that the shoulder in this case can be radiographed using the same technique that we used for the knee, because it is the same measurement, 10 centimeters. And that the minimum KVP that we use for the knee is also the same for the shoulder, because it's good enough to penetrate the part. It'll penetrate both of them. So that's a good way to look at it. If you don't know the technique for a certain part, just think of the measurement. Is that part thicker or thinner than the exam that you just did previously? And then you can figure out if your exposure can be the same or more or less. For special considerations, we need to be able to recognize the patient and equipment variables. So not every patient is the same, and not every x-ray equipment is the same. So we need to be able to recognize that and adjust for that. We need to have a thorough understanding of how the variables affect the resulting radiograph to make adjustments to produce a quality image. So our special considerations are pediatric patients, geriatric patients, bariatric patients, different projections and positions, patients that have casts or splints, pathological conditions, soft tissue, contrast media. So, we're not going to always have a patient, a walkie-talkie ambulatory patient that, you do a chest x-ray on, everything's perfect, they leave the x-ray room, and, so on. Sometimes we're going to have special considerations that we have to figure out which way to do the exam. Sometimes we have to use angles because the patient can't put their head in a certain direction for us, or they can't move their arm, or, just depending on where you work. If you work in trauma, you are going to be critical thinking big time. And, you're going to have to make all kinds of different adjustments to be able to get the image that you want from a patient with these special considerations. So we will talk about each one of these next. Pediatric patients are a technical challenge for radiographers for a number of reasons. With pediatric patients, they require lower KVP and mass compared with adults. We use fast exposure times so that they don't have a chance to move and we get the exam done quicker. And their lower bone density may require a reduction in the exposure. With pediatric chest radiography, this requires us to choose fast exposure times to stop the diaphragm motion in patients who are not able to suspend their breathing. For example, you can't tell a 6-month-old to hold their breath, right? So what we do is we watch the chest rise and fall, and as soon as you see the patient or the child breathe in, then go ahead and hit the exposure button. What a fast exposure time does also is it prevents the patient from moving. We get the exposure done quick, they don't have a chance to move, and then we get a good diagnostic image. The only downfall is a fast exposure time may eliminate the possibility of using an AEC system, so you will have to set a manual technique for that. For geriatric patients, these patients may experience physical changes such as limitations in hearing, vision, and balance. Also, their skin is thinner and more easily torn or bruised. So be careful when you are transferring them from wheelchair to x-ray table or from bed to x-ray table because of their thinner skin. Psychological changes in the mental state of the geriatric patients may affect their ability to follow instructions during the procedure. So we should always be prepared to provide enhanced patient care in terms of additional time for the imaging procedure. We need to be sensitive to the patient comfort by using a table pad. We need to use positioning sponges, get a blanket out of the blanket warmer, and attention to the safety of the geriatric patient during the transport on and off the table, and also during the positioning. Make sure that the patient knows that they're not going to fall off the table, okay? Keep them safe. Keep communicating with them. That's the best way there, too. And also, exposure techniques may need to be decreased because a lot of our geriatric patients are thin and frail. Tissues may be lower in subject contrast and therefore are going to require a decrease in KVP. This is going to result in a higher subject contrast. And to eliminate motion with the geriatric patient, it is recommended for the radiographer to adjust the MA and exposure time. So just like we did with pediatric patients, we want to use a faster exposure time or a shorter exposure time to get the exam done quicker. Imaging patients who are categorized as obese are becoming more common in radiology. Now that we have bariatric surgery, this is becoming more routine, and therefore imaging procedures may be needed both before and after the bariatric surgery. Bariatric patients bring unique challenges in terms of their weight and body diameter. There's important issues to consider when you're imaging a bariatric patient, including the table weight limit and the size, diameter of the fluoroscopic imaging equipment. Also, when a bariatric patient comes in and they need a CT or MRI, a lot of the times their shoulders will not fit through the gantry, which is the donut hole. So they might need to go to a different site that has a larger scanner. Bariatric patients will need an increase in both KVP and mass to produce diagnostic images. In addition, you will use a grid. It's very important to use a grid because we're using higher technique. So we want to reduce the scatter radiation from reaching the IR. If we don't reduce that scatter radiation, then it's going to decrease the image contrast, and we don't want that. We want high contrast. So depending on the imaging procedure performed, these patients may need to be imaged in quadrants. So if we do, let's say the patient is, 500 pounds, okay? Pretty large patient, they're laying on our table. Now most tables have a weight limit of 350 pounds. So they would have to go to a special center that will accommodate a 500-pound patient. So there are places that do have tables that will accommodate that. So let's just say our patient is large. They're a bariatric patient, and you need to do a KUB. Well, you're not going to get a KUB in one picture. So you might need to do quadrants. So you might need to take a 14 by 17 of the right upper quadrant, then the right lower quadrant, then the left upper and left lower. And you'll take all 4 images for the doctor to see, because that's how large their abdomen is. And we want to make sure that we get all the anatomy in there. And then before you send it through PACS to the radiologist, just, label the films like 104, 204, 304, 404. And that way they know that there's quadrants for one exam. There's different radiographic projections and patient positions that we do of the same anatomic part. And this often requires a modification of your exposure factors. For example, an oblique position of the L-spine is going to require more exposure than the AP because of an increase in the amount of tissue. Just like anytime you go from a PA to a lateral or an AP to a lateral, you're changing your technique, because going through an AP is less tissue thickness than when you turn and go through the lateral. Now you've got double the tissue thickness. So we always, we always want to make sure that our exposure factors are changing from one position to another. Casts and splints can be produced with materials that attenuate X-rays differently. So selecting appropriate exposure factors can be challenging because of the wide variety of materials used for these devices. So we need to pay close attention to both type of material that's used and how the cast or splint is used. Casts can be made of either fiberglass or plaster. Fiberglass requires no change in exposure factors. Plaster requires an increase in exposure factors, and even more of an increase in exposure factors if the plaster is still wet. So the way you know how much to adjust the exposure factor is you look at the part thickness using a technique chart. So for example, if an AP ankle measures 4 inches without a cast, and then it measures 8 inches with the cast, then you're just going to look at the technique chart and you're going to put your exposure techniques to that of an ankle measuring 8 inches. And then you will get an acceptable radiograph. Splints present less of a challenge determining the exposure factors. There is an inflatable air splint and fiberglass splints, and they do not require any increase in exposure factors. But then there are wood, aluminum, and solid plastic splints, and they might require exposure factors to be increased, but only if they are in the path of the primary beam. So for example, sometimes they will splint the tib fib on the medial and lateral side, and when you're doing an AP, that's not going to be a problem. But then when you do the lateral, then it will be in the primary beam, so that will be a problem. So you will have to increase your technique at that point. Pathologic conditions can alter the absorption characteristics of the part being examined, and they are divided into 2 categories: additive diseases and destructive diseases. The additive diseases are diseases or conditions that increase the absorption characteristics of the part, making the part more difficult to penetrate. Destructive diseases are those diseases or conditions that decrease the absorption characteristic of the part, making the part less difficult to penetrate. So for additive diseases, we will have to increase our KVP, And for destructive diseases, we will decrease our KVP. So we don't know an exact amount or percentage of KVP that should be changed because of the state or severity of the disease or condition. So it's going to be different with each patient, but we can use the 15% rule. So a minimum change of 15% in KVP is recommended. And there are some instances in which a change in mass may be more appropriate, just depending on the pathologic condition. But as a rule of thumb, we use KVP. We'll increase or decrease the KVP. So objects such as small pieces of wood, glass, even swallowed bones are difficult to visualize using normal exposure factors. So with digital imaging, there are no alterations required. We can just window width and window level until we see the good soft tissue. And you want to make sure on a soft tissue neck that you get all of the air coming from the mouth all the way down, because we're looking at the larynx. So we want to make sure that there is enough air in there so that the doctor is able to see it. With a soft tissue technique, we are using decreased mass to visualize the larynx. So we're looking, usually soft tissue is for young children. We're looking for croup, a possible foreign body obstruction in the throat, and we're looking for the foreign body location. Contrast medium, also called contrast agent, is used when we're imaging anatomic tissues that have a low subject contrast. The contrast medium is a substance that can be put into the body by injection or ingestion. We can give it to the patient either orally or rectally, or we can inject it into their vein. The type of contrast media used changes the absorption characteristics of the tissues, and it increases or decreases the attenuation of the X-ray beam. So we have different types of contrast media. There is positive contrast agents, and these contrast agents are barium with an atomic number of 56, and iodine, atomic number 53. They have high atomic numbers and absorb more X-rays, which increases the attenuation of the surrounding tissue. The negative contrast agent, such as air, has an atomic number of 8. It decreases the attenuation of the X-ray beam and transmits more radiation than the surrounding tissues. Positive contrast agents produce more brightness than the adjacent tissues around them, and then the negative contrast agents produce less brightness than the adjacent tissues around them. Even though the negative contrast agents are going to decrease the attenuation of the part being examined, their use does not require a change in exposure factors. The negative contrast agents can also be used in conjunction with positive contrast agents, like for a double barium enema study. We're using barium and air. The positive contrast media studies require an increase in exposure factors compared with imaging the same part without contrast. So the use of a contrast agent is an effective method of increasing the subject contrast when imaging areas that have a low subject contrast without the contrast media. The quality of the image depends on a multitude of variables. Knowledge of these variables and their radiographic effect assists us in selecting the exposure techniques to produce the radiographic exams. This picture here, this is a radiographic image showing increased brightness because of the increase in the X-ray beam attenuation, because we've used a positive contrast agent. Positive contrast agents are going to produce more brightness. and negative contrast agents produce less brightness. And in this picture here, you can see it's a radiographic image showing decreased brightness because of the decrease in X-ray beam attenuation. And we're using a negative contrast agent. So we're using air. So that is a double barium enema that we're seeing there. And that is a decubitus. So on a decubitus, the air rises and the barium falls down to the bottom. So you can see the air fluid levels